Hi, I'm Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, and for the month of August 2021, I have picked two topical and related articles on COVID-19 vaccination in patients with rheumatic diseases. Today, I'll be interviewing Dr. Glen Hazlewood from the University of Calgary, Canada, who is the first author on a paper entitled Canadian Rheumatology Association Recommendation for the Use of COVID-19 Vaccination for Patients with Autoimmune Rheumatic Diseases, and the papers by Dr. Hazlewood and colleagues on behalf of the Canadian Rheumatology Association. This paper is currently available for viewing on the journal's website at jrheum.org. Glen, I want to thank you for taking the time to speak to me and our listeners about your timely article on the Canadian Rheumatology Association recommendations for COVID-19 vaccinations for patients with rheumatic diseases. And anybody in the world knows these are always changing. Our governments are changing all the time. So I think this is super important. Anyway, my first question is, could you just highlight the important findings of the article?
Yeah, thanks so much for having me. Yeah, the main finding is quite simple. The main message from the article is that vaccines for COVID-19 are recommended for patients with autoimmune rheumatic diseases. The panel, the multidisciplinary, so we had a panel with rheumatologists, patients, vaccine experts, and methodologists. And the panel was unanimous that the benefits outweighed any theoretical harms from the vaccines. I think another key message was the panel was very clear of that patients shouldn't have to go through additional steps or barriers to access the vaccine. You know, the vaccine rollout, of course, is very different from typical vaccines where you sort of have a, you know, they're out and patients come into your clinic and you can have sort of lengthy discussions with people. Here it was, you know, everybody has the vaccine available now, and we really wanted to avoid any delays that may occur through additional steps. Yeah, so those were, I think, the key findings from our guideline.
Thanks. It's always important, I think, to go over methodologies for guidelines, and if you could briefly outline the methodology used in these guidelines.
Yeah, absolutely. So as I mentioned, we first assembled the panel, so panel of relevant stakeholders. And then we used the GRADE approach to develop our guidelines. This is now the official approach of the Canadian Rheumatology Association. It's also the same approach that the American College of Rheumatology uses and many other groups. And essentially, to boil GRADE down into a simple approach, the first step is reviewing the evidence. And within GRADE, when you review the evidence, you first define what are the key outcomes you're interested in. And then for each of those outcomes, you develop a summary of the evidence and an estimate, the best estimate for the treatment effect. And then you grade the evidence. And in GRADE, the evidence, you're essentially grading the certainty of each outcome. So high certainty outcomes mean you're very confident in the estimate for that outcome. And low or even very low certainty evidence means you really have a lot of doubt in terms of what the best, whether your summary estimate is the true effect. And then moderate is somewhere in the middle. So you go through that process, and there's a bunch of different things you look at when you're grading the evidence. And then after you've done that, the next step within GRADE is to go through what's called the evidence to decision process. And this is a systematic way of going through all the considerations that you should go through when you're developing a recommendation. So this is the first is just the evidence, what it shows and what the certainty of evidence is. And then you go through factors like patient preferences, do the benefits observed outweigh the harms, and that's where patient preferences come in. And then equity considerations, resource use considerations. And for each of those, I think the one key thing to keep in mind with grade is these are judgments that need to be made. So, you know, anytime you're interpreting evidence, you need to make judgments about it. And grade doesn't take away those, but the intention is to make them transparent and have a systematic process so people can see what judgments went behind the recommendation. That's
great, thanks. It'll help people not only for this paper, but grade is everywhere.
Yep, exactly.
Great. So one of the things is how do our guidelines, being Canadian, the CRA guidelines compared to other National Rheumatology Association guidelines?
Yeah, I think from the main message from the guidelines, you know, vaccines are recommended, really agrees with every guideline that's out there from any of the rheumatology societies. The main differences are the scope. So we took the scope and the methods used. So you know, we felt it was really important to use grade. And so we took a focused approach. So ours was really to make a formal grade, you know, recommendation using grade for the guidelines. So we had quite a narrow focus, so that's what sort of is a bit different from our guideline is we use grade for our recommendations. And then other guidelines addressed more questions. You know, the American College, the ACR guidelines do look at more questions. They use more of a consensus-based approach rather than grade. So those are kind of the key differences between the guidelines, but the overall messaging across them is the same, is consistent.
Thank you. It's very helpful. In the discussion, you comment on the approach used by the National Advisory Committee on Immunization in Canada. For those who are Canadian, this is our national guideline, our National Advisory Committee, who really sets the policy of who gets immunized. These are the guidelines, it's our government that sets it, but they listen to these people. And you said there were differences in the approach and some at least the recommendations at the time, and these are ever-moving target. So could you just say a little bit about the approach differences, why, and I guess the recommendation differences you can comment on sort of with the last question.
Yeah, absolutely. So the NACI group, as you mentioned, develops these recommendations, which are then kind of implemented by the provinces. And this really gets back to our sort of rationale for using grade. The NACI group uses grade, so we really felt it was important to use the same methodology. And that was really kind of the driving rationale behind what we did, is we really wanted to make a recommendation with rheumatologists and patients and sort of the clinical and content experts that would try to shift policy. Because when NACI came up with their initial recommendations, because the challenge is, you know, none of our patients were included as part of the clinical trials. So NACI had come out initially with a recommendation and, you know, said because our, you know, people with autoimmune rheumatic diseases were excluded from the trials, we shouldn't be using the vaccine in these patients. And so really that was kind of the main impetus for us to do this work, is we felt that there was you know, that wasn't the right message, and that's kind of what led us to do this. In terms of how we use the same methods and came to a different recommendation. And I sort of, just to couch this, NACI has since edited the recommendation, so the vaccine is now being offered. And across the provinces now, we're hearing, I'm certainly hearing less and less barriers of people getting the vaccine. It seems the message is now sort of out there that people should be getting vaccinated. We really felt that this issue was a question of indirectness of the evidence under grade. And so that's one of the sort of, when I talked about grading the certainty of evidence, that's one of the considerations is indirectness. And that really means, if you have evidence, how applicable is it to your population? And we really felt that we did have good evidence on these vaccines. It's just that people with rheumatic diseases weren't part of those trials. And so that led us to rate down the certainty of evidence for both the benefits, because people may not get the same benefit because of the medications they're taking. Also for the adverse events, we rated it down because there's theoretical risks that may occur in these patients. But even after doing that, it was quite clear that the magnitude of the benefit outweighed any of these theoretical risks. So that was kind of one key difference, is how we approached the judging of the evidence. And that was all sort of in keeping with grade guidance on how to assess indirectness. And then I think the second key difference is just bringing in that patient voice and the content experts, the rheumatologist, the patient voice from the rheumatologist plus the patients that were part of the panel, and to just, come to that agreement that these trade-offs that we're dealing with really are far weighted towards the benefits of getting the vaccine.
Yeah, I hope. Certainly it did change, and anybody practicing in Canada knew you had to write letters to get your patients to beg, borrow, or steal, as it were, a vaccine. And that is a thing of the past. So yeah, I commend the CRA and hopefully other national organizations to do the same thing if there are barriers. So my last question, really, one of the important things that we discussed when we initially discussed about publishing this article, the idea of a living guideline. And obviously, these have to be, particularly with this, a living guideline, as the information is ever accumulating. And again, it mentioned in the article the reference to the CRA website. So are there any new recommendations yet from the CRA? Any updates?
Not as of yet. The recommendation is current, sort of the published one. But yeah, that's a really key point, is the journal article is as up to date as we had it at the time of publication, and then they will live on the can be linked through the CRA website. We have, I will mention, just started a Cochrane, the protocol is now published, a Cochrane review, and that's going to be a living systematic review as well. And we've started that, and that'll look at vaccine safety and efficacy in people with autoimmune rheumatic diseases. So that's kind of going to be one of the vehicles that we use to keep these guidelines updated.
Well, that's great, because as you said, we assume the only theoretical risks, as there have been for most vaccines, which we haven't seen, including disease flares. But really, one of the things that you wonder about in the evidence is moving forward slowly, that some of the immunosuppressive drugs may blunt the response, and the possibility of requiring a third or second booster. So we look forward to this. That'd be great.
Yeah, absolutely. There's
an update.
Every time I relook at this, I've done a couple presentations on this, and each time I relook at it, there's another 2 or 3 studies that are out. So there's, rapidly accumulating evidence in our patient populations.
Well, that's great. So Glen, I really want to thank you for taking the time to speak with me, and for the listeners and to the viewers. Please read the full-length article, Canadian Rheumatology Association recommendation for the use of COVID-19 vaccinations for patients with autoimmune rheumatic diseases by Hazlewood and colleagues on behalf of the Canadian Rheumatology Association. I'm going to ask you a sort of irreverent question. How come it said recommendation and not recommendation? Just out of curiosity, and caught you completely off guard with that one.
We used the singular instead of
Yeah,
the,
you use a singular. I listened to my wife in my ear saying, "Why ask them why they didn't use the plural?"
Well, I guess, yeah, it's a good point, because we did just formally develop one recommendation, but they may actually add other ones over time. So yeah.
All right, thank you. Now I feel better. That's great. All right. In addition, I would invite please read the editorial by Dr. Katie Beckman and colleagues entitled "The COVID-19 Vaccination Landscape: What a Rheumatologist Needs to Know." And I would also listen to my interview with Dr. James Galloway, who is a senior author of the editorial. And we'd love to hear your comments on Twitter at jroom or by email at manuscripts@jroom.com. And I want to thank everybody for joining us, and hope you will listen to my interview with Dr. Galloway after you've heard this one on his editorial of the COVID-19 vaccine landscapes, what a rheumatology needs to know. And please join me next month when I speak to one of the authors of one of my September picks. I've been talking too long, so and bye for now, and keep well.
Thanks.